want to make this long and drawn out. Yeah?
When the ductus arteriosus disconnects, does it just like tear a hole in the aorta?
It can either cause a dissection, which is why everybody who gets in a car crash gets a chest x-ray. Deceleration injuries cause that. They could just be, oh, I just hit my chest. And then later on develop a dissection that goes all the way down. And on a chest x-ray, you can see that as widening in the mediastinum. So when everybody who comes to me, if they were in a car crash, they get a chest x-ray. If it completely disconnects, that person was dead at the scene. Because they'll fill if they die fairly quickly, they would die of a tear that filled their pericardium with fluid and get tamponade, and that's the way it kills them. But most likely it would just pull all the way out, fill their pericardial sac, loss of pressure. If you ever stood up too fast, you get that blackness. A hole in the aorta causes instantaneous loss of pressure and not enough to keep your brain awake. So that's they were in the car crash, they never woke up that fast. Any other questions about the heart? Does this make it more clear how to memorize it? If you guys want these. This is my little box heart drawing about how this works, because you really need to think of yourself as having two hearts. Congestive heart failure happens when your lungs, let me draw this real quick. Extra credit, or extra time. You really have one lung and two hearts. One heart that fills them, one heart that sends it to the rest of your body. So this is your left heart, this is your right heart. Now people who come in with congestive heart failure have a whole bunch of fluid in their lungs, we'll say, okay? They need to get that fluid out of there. But the problem is, all of this stuff is backed up into their system, so that the right side of their heart has huge veins going into it that are completely distended, which is preloading the right side of their heart and overfilling their lungs with fluid. Can you see that? Meanwhile, we call it congestive heart failure, but their blood pressure when they come in is 190 over 120. So their heart valves aren't even opening until 120, right? And then they're only getting a little bit extra pressure, and it's 190. So too much for this to overcome. So the left side of the heart can't get the blood out, and the right heart is pumping it into the lungs really fast. So how do we treat that? We treat them like there's two hearts. Okay, these are arteries. What do? We decrease this pressure. If we decrease this pressure, we can give some people some Lasix. I don't even know if you know what that is, but we give some people some Lasix. We made them pee off the fluid, decrease the volume that they have, and drop this number, which we call afterload, right? You drop their afterload, you increase how well the left heart works. Does that make sense? I give them nitro. Nitro on this side is a venodilator. And as a venodilator, it decreases this preload on the right side of the heart and decreases how much they overfill their lungs. Does that make sense? Okay. And then if I want to be super aggressive, I actually can then put them on CPAP, which is pressurized ventilation that's blowing into their lungs, so that I actually put pressure on this water column and push it harder into the left side of the heart. And that preloads the left side of the heart. So it's easier for the left side of the heart to pump it out. Does that make sense? So this is what I mean as far as if you think about the heart being this way, you have two hearts, a right side and a left side. And other than being stuck together, they function independently. And the reason they're stuck together is because you need the ductus arteriosus and the foramen ovale to survive in infants, in fetalhood. Okay? And that transition, understanding that transition, and then for the rest of your life, treating them completely separately is important. Okay? And here's another quickie. He keeps saying that, but then he keeps talking. Okay, here's another one. What is left end diastolic volume? Or left end diastolic pressure? Nobody knows. What is venous pressure? Okay, what is your normal mean venous pressure? Okay, it's 12. Okay, and your atrium on the left side, its pressure is 12. Okay, and what that means is you don't need the right. I'm going to try to draw this. I swear to God, I'll try to go fast. So they don't have much of a right side of their heart, and they have a normal left side of the heart. And the only way they live is if they have a ventricular septal defect. Okay? So that blood gets pumped into their pulmonary trunk because of their left ventricle. It's a permanent left to right shunt. Are you with me so far? The only way they live is because of this, because this is not strong enough to pump. So what you do is you have the superior vena cava and the inferior vena cava. And the very first thing you do with these kids as they're babies is close this and put a shunt into their vena cava. Later on, when they get a little bit bigger and their pressures change, you take the inferior vena cava off and you shunt it directly into the pulmonary trunk. The last procedure, you don't even know all this stuff, but the last procedure is called the Glenn. And in a Glenn procedure, you cut off the superior vena cava, you take out the shunt, and now the superior vena cava and the inferior vena cava go directly into the pulmonary trunk. And the right side of your heart is useless. Okay? Because now this blood flows directly into your pulmonary trunk, and your the left side of your heart sucks the blood out of your lungs continuously, causing it to just filter in from the other side. Now the weird thing about this is a surgery that was done in the 60s, and nobody knows how long they live. And the only people who can take care of these people are pediatric cardiologists. So you're in the pediatric cardiology office, and there's, a 5-year-old and a 3-year-old and a 54-year-old, because nobody else knows what to do with his heart. Now they have almost no exercise tolerance, of course, because you need your heart to really increase cardiac output in order to be able to exercise. But these people are walking around with no right side of their heart, just a left. So that's why I say, when you're older, you don't need a right side of your heart. Not for when you're resting. Does that make sense? And that's why you should treat your hearts as separate once you're treating them as an adult. Preload for the left side of the heart, preload for the right side of the heart. Think of them independently. That's my clinical correlates. Any other questions? That's all I got.